Okay. Hey everyone, thank you so much for coming today. We are starting off our first virtual interview with Dr. Kalra. And my name is Olivia Rajan. I'm the president of Operation Education. Eugenia, do you want to?
Hi, my name is Eugenia Lee. I'm a communication manager for Operation Education.
We will be conducting Dr. Kalra's interview today.
I'm Isabel Lopez, and I am the vice president. And basically what's going to be happening is Dr. Kalra is going to be answering some of our questions, and that's about how it's going to go. This is recorded for our podcast, right? Or is it just
podcast and YouTube? Yeah.
Okay. Yes, and it'll be going on those.
Yeah.
Is there anything else what I'd like to say?
No, other than that, yeah. So we prepared 10 questions beforehand from both our followers on Instagram and what our officers came up with. We'll be asking those so that we can get a deeper insight on Dr. Kalra's specialties. And after that, everyone who attends will be able to earn shadowing hours by answering a really short 10-question multiple choice quiz. If you get a 70% or higher, you do get the hour, the service hour. So that will be coming to you in an email. And I think that's all the information and that you guys need to know. We're just going to go ahead and get started now. Does anyone have any questions they want to ask before we start? Okay. If you guys do come up with any questions throughout the interview, you can always send them in the chat to either Dr. Kalra, me, Junior, Isabel, and we'll ask either depending on where we are, either in the middle of the interview or afterwards. So yeah, if you have any questions, just send them into the chat. So we're gonna go ahead and get started. The first question is, Dr. Kalra, could you briefly introduce yourself, such as what specialty you're in and how long you've been practicing?
Sure. Hi. Thanks so much for having me, guys. And I hope that you find this informative, and I like to keep it casual. So please feel free to ask me any questions or if you need me to repeat anything, and I'd be happy to do that. So I am actually board specialized in internal medicine, in gastroenterology, and in obesity medicine. And I have been practicing now as a gastroenterologist for 5 years, which goes by really fast once you get started. Actually 4 years technically. I graduated from fellowship in 2017, and my first job was at Stanford University, and that's before I was board specialized or board certified in obesity medicine. So I was only practicing gastroenterology at that time. I worked there for 3.5 years and had a baby last year. So kind of switched gears and am now practicing in private practice in Newport Beach, where I do both gastroenterology and obesity medicine.
So let's move on to the second question. Why did you choose gastroenterology over other specialties, and how did you decide, and what drew you to this field, and what factors influenced your decision?
Okay, great. So I chose gastroenterology. We also call it GI. So I may just say that because it's a little less cumbersome on the mouth. But I chose GI because it's a combination of procedures and office-based practice. You can kind of make it whatever you want. And, I got really inspired when I was in med school and I was on my rotation with the other GI folks, and everyone seemed really interested in what they were doing. And it felt really nice to, although I couldn't myself do procedures at that time, but be a part of the experience of doing procedures. And if someone is bleeding, or if someone has swallowed a fish bone that's causing an obstruction or something, to be able to kind of use your hands to take care of the problem. As far as factors to consider, I think there's, you kind of figure out what you as a person want out of your career. And I think anyone going into medicine is usually pretty empathetic and compassionate and really wants to help other people. And I think that as you go through each step, you kind of figure out which way you think you would be best able to do that. And for me, I felt that being able to be in a specialty where I speak to patients and really be involved in their care and maybe make difficult topics like bowel movements a little bit easier to talk about because I find that people feel comfortable talking to me. Those were things that I knew I could offer. Whereas, some people, some of my really like my best friends don't really love talking to patients so much, but they love medicine. So they may go into radiology like my husband did, or pathology where you aren't really so much interacting face to face with patients, but you're still making a really big impact. So I would say my advice, if you're, thinking about which career is to do these sorts of things, is to learn about what each specialty really is, what it feels like day to day. And then when things get better and, practices are opening up a little bit more, really go in and shadow. And if you're thinking, maybe I want to do cardiology, or maybe I want to do psychiatry, or whatever it is, try to get as much of a real world example as you can during med school. That's kind of what my biggest advice would be to people who are considering it, because you really don't know until you're doing it what it's like. Because on paper it can look very different. If making a certain amount of money is really important because there's loans to pay off or just personal desire, then you can also search to see which specialties make more money. That wasn't a big driving force for me, but out of the internal medicine subspecialties, cardiology and GI tend to be higher earning because we do procedures, so that just brings in more revenue. But again, that wasn't like a major factor for me. It was really just what I felt good doing. On a personal note, there really weren't a lot of women in GI at the time when I was kind of rotating through it. And I felt like it was an underserved population almost, because I know women tend to feel more comfortable with women when it comes to certain symptoms and things to discuss. So I kind of felt that I would be able to at least help bridge that gap for a lot of women who otherwise weren't seeing a gastroenterologist. My mom was one of those people, and my grandmother had colon cancer, and it took me forever to convince her to get a colonoscopy, even though she was overdue for it. And she said, fine, well, there's one female GI, 40 miles away, so I'll just go see her. But literally like that was with my own mom. So, it's really, I find that it's been great in that way, that I think that I get good feedback and that women feel happy that there's a female gastroenterologist that they can kind of speak to about certain things. So did I answer all of those questions? I know there were a few.
Yeah.
Okay. Okay.
The next question kind of goes off of the previous one. So what is the most appealing aspect of gastroenterology? And if you could go back in time, would you choose a different specialty or even a different field? Why or why not?
Great questions. So what's appealing about it is that you get a nice balance of procedures. So we do procedures called endoscopies and colonoscopies, just to name kind of the bread and butter ones. So these are essentially where you take thin camera tubes and we're allowed to look inside the patient's food pipe or their esophagus, the stomach, and the first part of the small intestine. That's what an upper endoscopy or EGD is. It usually takes about 5 to 10 minutes. It's pretty easy, and once you get the hang of it. And patients are usually under anesthesia, so they're sleeping during the procedure. And you're able to do biopsies which is taking samples of tissue from inside. Patients don't feel it. It doesn't hurt in that sense, but it's a very informative procedure. And colonoscopies are similar, but they're a little bit longer, and they're done obviously through the colon, through the bottom, and patients have to clean out. And we do that test to look for colon cancer and look for polyps and other things. And, I love that I'm able to do that procedure and do procedures as part of my day. And I also love that I get to be in the office and do consultations as a part of my day. So for me, that was the most appealing thing, was that I was able to use my hands as part of my asset, I guess, to bring to the table. And part of my kind of educational, studies was doing procedures. And I really enjoyed that. I felt that I was able to make a difference by using my hands, which you can't do in a lot of medicine subspecialties. If I had to choose another subspecialty, honestly, I was really on the fence about critical care. Pulmonary and critical care tend to go hand in hand. It's not really common to do just pulmonary anymore, which is lungs, as you guys I'm sure know. But I was between the two, and my father is a pulmonologist, so probably that had something to do with it. But I really enjoyed being in the ICU. One of the major reasons why I chose GI was because patients who are in the ICU, as you guys can probably imagine, can be very, very sick. And having a lot of conversations with family members and giving bad news was starting to get to me emotionally. And that was a major reason why I didn't choose ICU medicine. I found that it was just, I maybe perhaps wasn't as thick-skinned as one needs to be for that. And I felt that GI just was able to give me everything that I wanted, and, you know, in a career.
Okay, so the next question is, in order for someone to specialize in gastroenterology, how many additional years of medical schooling are required?
Okay, so if it's the 4 years of medical school, and then you will do an internal medicine residency, which is 3 years, and then a GI fellowship, which is 3 years. So it's a total of 6 years after medical school to become a gastroenterologist. Now, there are even subspecialties within GI for which you can get additional training. So it probably is a little bit complex, but basically there's certain procedures to look specifically at your bile ducts. That's called an ERCP. So as I mentioned, as a gastroenterologist, I do endoscopies and colonoscopies. This is a special type of endoscopy, and it's a very specific skill set. And so in order to learn how to do that, you are considered an advanced endoscopist, and that fellowship is usually 1 year additional. So if you wanted to do more advanced type procedures, and now they're doing actually, honestly, almost like surgeries from the inside, it's pretty amazing. You would do an additional 1 year. So that would be a total of 7 years. But if you wanted to be a general gastroenterologist, it would be 6 years after med school.
And another question someone asked was, do all colleges offer gastroenterology specialization? And which college is the best to study this specialty?
So I think what that person was asking was, it's every hospital has a GI fellowship, like every university hospital. I would say a vast majority do. There are very few hospitals where there are no GI fellows anymore, because there's so many patients who come to the hospital with GI bleeding or GI symptoms that they really, more often than not, do have a GI fellowship. As far as which is the best hospital, you know, UCSF, Stanford, Harvard, pretty much the same as what would be considered the best in any other Mayo Clinic. You know, those are kind of the main hospitals where people, I guess, would say it's like the highest ranked. But to be honest, Cleveland Clinic, there's so many. And what I will tell you guys is, you know, personally, I didn't go to Stanford for fellowship. I didn't go to Harvard for fellowship. I went to SUNY Downstate, which is a university program, but still very county based. And in a program like that, you actually get a lot more procedures. So you perhaps, if research is really important, then I would say the answer is probably a higher tiered academic center. If you think you want to pursue a career doing a lot of bench research, or, you know, kind of just the research in general. If you really want to be a clinical practice kind of person and be in your community or in private practice, then doing a fellowship at one of these more robust, really difficult on a lot of levels, and more, we call them kind of like malignant programs, is probably your best bet. Because, you know, I finished all of my required procedures in the first year of a 3-year fellowship, whereas some of my colleagues at a, you know, Ivy League would have taken 3 years to do the same amount of procedures, because they focus so much on research. So they have an entire year and a half just dedicated to research, where they may or may not even touch a scope, you know. So it really depends on what you want long term. But I would say if you want to focus on clinical and be, you know, really feel really confident in your procedural skills, then going to a place where they, you know, you can look for that when you're applying, is what's your kind of a volume of procedures, and how long does it take to meet that goal that everyone is required to do before graduating fellowship.
Perfect. Thank you for explaining that.
Sure.
So another question that I thought was pretty interesting was, how did the rise and spread of COVID-19 impact your career?
So, I get asked this question a lot, but actually I was on maternity leave. Like I had planned it on March 1st was my last day, or some like February 28th was my last day. So March 1st, I was on maternity leave. And as you guys know, like mid-March is when everything kind of shut down. This is of 2020, right? So I was basically on maternity leave through that entire time. But what did happen is, so at that time I was working at Stanford, and before COVID, I was flying back and forth to San Francisco. So we live in Newport Beach, but I was flying to San Francisco. I would work for 2 weeks and then I would fly back. So I was getting on a plane like 3 or 4 times, four times a month or so. And then I had the baby, and with COVID still in the air, I literally couldn't justify getting on a plane back and forth. So I was working virtually. So I was seeing patients over Zoom, and I mean our like platform through the medical software. And that's how I was able to actually work from home a little bit. So I obviously couldn't do procedures because with Stanford, because I was living here and I couldn't fly back and forth. That was a major reason why I had to choose to stop working there, because it was just not realistic to travel anymore. But for me, COVID was kind of a blessing in that way, because I was actually able to work from home more, and I was able to figure out what was important to me and kind of take a step back and think about what's important to me from a career standpoint, and my future, now having a family. And I think for a lot of women that inevitably comes up. So if you're thinking about having a family one day, it's important to reflect on that when you're choosing a career as well. As far as, other like specifically COVID, like seeing COVID patients, I actually stopped going to the hospital when I resigned from Stanford. So my job right now is only outpatient. So I haven't really seen any COVID patients. So I'm not the best person to ask, I guess, that question, because I wasn't really a part of it. But for me, it was great because I was able to kind of work from home, and in that sense, from a career standpoint, not from any other way. It was a horrible situation for everyone, but just from a career standpoint.
Congratulations on having your kid.
Oh, thank you.
You're welcome. So the next question is pretty lengthy, so I'll just go step by step.
Sure.
The first one is, can you walk us through a typical day in your life?
Sure. So right now, I'm not going to lie, it's pretty good. I make my own schedule, and I kind of work for a colleague, now, but pretty much it's my own practice, so I can do what I want to do. So on Tuesdays and Wednesdays, I go to the office and I see patients. So consultations, some patients choose to do it virtually, which is fine. A lot of them still like to come into the office, which is perfectly fine. So I go to the office, which conveniently is about 5 minutes from where we bought our home. So that's nice. And right now I only work in the afternoon. So I get there around 1 and I'm done by like 4. And I do that on Tuesdays and Wednesdays. And then Thursdays are my procedure mornings. So I go to the endoscopy center, which is attached to our office, which is also really nice. I do procedures. And like I mentioned earlier, upper endoscopies take like only about 5 to 10 minutes to do, but they obviously get anesthesia. So it takes a little bit of time. So about half an hour to 45 minutes for each procedure. And I'll do probably 4 to 6 procedures. And then in the afternoon, I see patients. So if I want to, I just come back to the office and I'll see a few patients, and then I'll be home. So for me right now, this schedule is like what I always dreamed of, because I knew that I wanted to be home and be present with my family whenever that happened. And so that's my schedule right now. At Stanford, maybe that would be more of a, traditional type of schedule. I would do office days only on Mondays, Wednesdays, and Fridays. And then that means I show up at 8 o'clock and I'm there till 5 o'clock, seeing probably about 16 patients or so. That's roughly about 40 minutes for new patients, 20 minutes for follow-up patients. And so you just kind of are in the office. I had a nurse practitioner that I would work with, so that was nice. So she would see patients while I was seeing patients, so we could see a lot more. And so what it means to have a nurse practitioner work with you is that they will see a patient, and then they will come out of the room and kind of go through whatever they discuss with the patient and have their plan. And then you go in and make sure that everything is kind of in line with what you're saying and what you would do. And then that's it. So then they take care of all of the follow-up and all of the inputting of orders and things like that. And then on Tuesdays and Thursdays at Stanford, I used to do procedures. So those are 7 a.m. to 5 p.m. just procedure days. So I was doing about sometimes 16 procedures or so, which can seem like a lot, but once you get going, it's a fun, fast-paced day, because between one procedure and the next, you just kind of go. After you do a procedure, you write a procedure note in the chart, and then you print that out for the patient. You discuss their findings with them. By that time, they're getting the next patient in the room, and it just literally moves like clockwork. It can get really tiring sometimes, especially when I was pregnant doing that procedures, so many procedures. So I had to like force myself to take breaks. But for the most part, it was great. I loved that schedule, and it was wonderful. As far as when you're on call, usually it's like a week at a time, including the weekend. And then you go to the hospital, you round on whichever patients are on the gastroenterology service, or whoever is needing to see a gastroenterologist, like a cardiologist may call you, or a medicine doctor team may call you. And then you go to those patients, you see them, you write a note and put in your recommendations. And that's pretty much it. That could vary. Sometimes I would be in the hospital for just a couple hours because we only had a couple of patients. Sometimes I would be there all day, even on a Saturday. I could be there from like 8 to 5. And if there's emergency procedures, we would do those on the weekends as well. Sometimes you have to go in the middle of the night. It does happen, because if someone, like I said earlier, if they swallow a fish bone and they can't breathe or can't swallow because of that, you have to go in kind of urgently to get it out. If someone is bleeding a lot and we think it's coming from an ulcer or something else that we can treat, then we need to go in as well. So those are kind of a little bit of insight into the day in the life, but it's very, very different. People set up their days however they want. There is a type of group of gastroenterologists that are called GI hospitalists. So they only go to the hospital. They don't do any outpatient at all. So you basically go to the hospital around 7 or 8, and you're just there until 5 every day, and then you take call. So I did interview for a job like that here in Newport Beach as well, in the hospital. But that was just, again, not kind of conducive to the life that I wanted, to be able to be home with my daughter, because by the time I'd be home every day, she'd be getting ready for bed. And to me, that it was more important to be more present for her. So you find what works, and you don't ever feel like you have to settle for something. Sometimes, like financial issues come up and you have to do whatever you need to do, but hopefully that's just for a short amount of time until you can kind of create the life that you want.
That's great. Thank you. So as a healthcare professional, I'm sure you've been busy a lot. Mm-hmm. So what are some things you do for fun or just to de-stress?
Good question. Well, now obviously my hands are full with Mia, but I love crafting. That's always been like something that I really enjoyed. So I try to make time to do that, whether it's making, custom cards for family members or friends. I love doing crafty things like that. And, like for her birthday party, I loved making, like DIY projects. It makes me feel really happy. I also love going on walks and meditating. That's a big thing, is finding different ways to relax and just be more mindful and more present. And I think that actually helps in a lot of ways, not only personally, but then also in my career, because it can be really overwhelming. As a doctor, you're always hearing about people's problems, and you kind of feel like everyone is sick, but you have to remind yourself that, you can't let yourself get too into that. And so mindfulness and practicing that is a really, really good way to do that. And I'd be happy to share kind of some resources if anyone is interested. That's kind of like a niche of mine as well in my practice that I use.
So the next question is, what was one incident you have seen or operated during your career that you'll never forget, or just really stood out to you?
Yeah, so actually I have a video of this one, which I thought was pretty cool. So I'm going to share my screen if I can figure out how. Is that something that you guys have to, oh, hold on, share screen. All right. Can you see? Okay, here we go. Can you guys see my screen here?
Yes, we can see it.
Perfect. So it already has like the audio running in the back, so I'll just show this to you guys. Okay.
This is a case presentation of a 62-year-old woman who presented initially for a screening colonoscopy. She was incidentally found to have a large lipoma in the transverse colon. 1 week later, she presented to the emergency room with acute onset of intermittent lower abdominal pain. While in the emergency room, she underwent a CAT scan of her abdomen and pelvis for further evaluation. Shown here with the red arrow, you can see the classic findings of an intussusception caused by the large colonic lipoma. The decision was made then to proceed with endoscopic removal. A large 7-centimeter submucosal lesion was seen in the distal transverse colon. As you can see here, it had overlying mucosal ulcerations. It had a broad base and was covering almost the entire colonic lumen. Submucosal solution was injected into the base as well as the main body of the lesion. Using the dual knife electrocautery technique, the overlying mucosa was incised in order to expose the underlying fat, akin to peeling back the skin of an orange. The underlying fat tissue was noted and was sectioned out repeatedly to detach it from the underlying muscle layer. Snare polypectomy was performed in a piecemeal fashion to completely remove the submucosal lesion. Due to the large size, the snare had to be used multiple times. A coag grasper was then used to coagulate any visible vessel. Multiple hemoclips were deployed to close the mucosal defect. Finally, an endoloop was placed around the hemoclips to provide a tighter closure. The incidence of colonic lipomas is reported as 0.04 to 4%. They most commonly occur in the ascending colon and cecum and are usually asymptomatic. Intussusception caused by a colonic lipoma is exceedingly rare. Traditionally, large colonic lipomas are managed surgically with a segmental resection. In this video, we demonstrated that endoscopic removal is an effective and less invasive alternative to remove large symptomatic colonic lipomas. Thank you.
Okay. So some of that might have been, let me stop sharing here. So some of that was probably a little bit advanced, but just to kind of summarize. So this lipoma just means like a fat ball, and people can often get them in their skin, but this was one that was seen in the colon. And this lady had just come in. We did a colonoscopy on her just for screening because she was above, at that time, 50. Now the guideline is 45, just so you guys know. So at the age of 50, you get it done. And this was the thing that was found. And you don't really do anything about them unless they cause some sort of problem. So for her, when she came back to the hospital, now she was having, abdominal pain. And so then that's why they did that CAT scan. And as you guys maybe saw, or I don't know if you could appreciate, I tried to label it with the arrow, but the lipoma was literally kind of like causing telescoping of the bowel into itself. So it's called an intussusception. Often that's seen more in kids, not so much in adults. As I mentioned, it's super, super rare. But this was a case where it was so big that it was actually causing this, it's called an obstruction or a blockage. So her options were she could get that part of the colon taken out. That's what we call a segmental resection. Or if an advanced endoscopist, like I mentioned, these are kind of like borderline surgeries, feels comfortable, then we can technically go in that way and do it. This had never been done before, actually. The doctor that I worked with, Dr. Iqbal, was just awesome, and he loved doing stuff like this. So and the lady did not want to get surgery. She was very, very, very adamant that she did not want to get surgery. So this was kind of like her only other option, and it worked out really well for her. So after the procedure, she basically went home the next day, and her main thing was she wanted to get back to Jamaica to be with her family, and if she got the surgery, she wouldn't be able to go, and she had her flight booked literally, and that was the whole reason why she didn't want surgery. So this was great because it allowed her to do that and go back home, and she was completely fine. So it's kind of a cool case, and there's a lot, you can kind of push the envelope in terms of what you're able to do endoscopically, but it's really safe, really well tolerated, and I just thought it was a really, really great case because it's super rare what we saw and how he did it.
Yeah, that seemed really interesting, and I'm sure everyone else found it too.
Mm-hmm.
So we're nearing the end of the interview. The last question is, what advice would you give someone looking to pursue a career in gastroenterology or just healthcare in general?
Sure, great question. And, I think the first step is really just showing interest, which obviously all of you guys are if you're here. And really just putting your best foot forward whenever you have any sort of a situation or an opportunity where you can network with people or meet people. That is really the time to kind of shine. And if you're presented with an opportunity, take it. Even if it seems challenging, even if it seems completely out of your scope, just go for it. And when you do that and you continue to kind of show people that you're going to be a hard worker and really put all of it in all the time, that's what's going to get you places. I went to a Caribbean medical school. I went to a county, type of a fellowship, and I was an assistant professor at Stanford. So if I can do it, anyone can do it. And it's important to keep your long-term goals in mind. And if there's some hiccups along the way, there will be hiccups along the way. Like if you can't get into a US med school and decide you want to go the DO route or go to the Caribbean, it's not the end of the world. Like I that's why I like to do these interviews, to show people that it's okay and you can actually get where you want to be. People might tell you, oh, you're not gonna be able to do this, you're not gonna be able to do that, but it's just not true. So don't let other people dictate what you are capable of. And just, it's going to be hard. It's going to be really hard, but it's going to be worth it.
Thank you so much, Dr. Carla, for joining this interview.
Sure.
Just to conclude, I have put Dr. Carla's Instagram in the chat, so if anyone wants to follow her, you can. And also, thank you so much for joining the Operation Meducation's first interview. And if you want to follow up, you can always visit our link tree with all our information and social media. And if Dr. Carla wants to plug in any of her socials or anything, she could do that right now.
Okay. Yeah. I mean, that's my Instagram right there. So if you guys, I try to post I'm just not really great on Instagram, to be honest with you, but I'm going to try to post a little bit more content so that it's relevant to people about GI things and mindfulness and stuff like that.
So that does conclude our interview, but we are going to open up a quick Q&A session. So if anyone wants to ask Dr. Kalra any questions about gastroenterology or just anything about medicine in general that you want to ask her, you guys can stay and either unmute or just ask in the chat. Yeah, and that's it. So thank you all for coming. Oh, looks like Zena has a question.
All right, my name is Zena, and my question is, what are since most of us are high school students, what are courses you need to take in high school to lead you to a profession in surgery?
In surgery specifically? I would say anatomy is really helpful, and the more exposure you can get to that earlier on would be very helpful. So really it's more what you do in college that can get you set up to get into medical school. But if your passion is surgery, anatomy is never going to change. You have to know all of the nerves and the muscles and the blood vessels and all of that. So the sooner you can get as exposed to that as possible, the better it will be for you. In college, once you're in kind of if you are on the pre-med track or the biosciences track, you will be going to do labs. And that's important, is to make sure that you do the right labs, physiology lab, anatomy lab. That way they can actually kind of get you through that. I'm trying to think, if I never did anatomy lab in college, I don't know if they actually had that, but in physiology lab, I know that we were doing frog dissections and things like that. So I would and things are also very different now than when I was in college. So I would just see kind of what's available, but anatomy is what I would say for anyone aspiring to go into surgery.
Thank you.
Sure.
Are there any other
Good luck, Zena.
Thank you.
I guess if no one else has any other questions, we're going to end the interview. Again, if you ever do have any other questions, you can always contact Dr. Kalra or even us, and we'd get right back to you. It looks like we have a question in the chat. I don't know if you can see that.
Yeah, I just read it. So I'm the eldest of three. And so I was in med school and both of my brothers were in college at the same time. So my dad could not afford to pay for all three of us for everything at the same time. So I had to take about 50% student loans. So I have around 90,000 right now in student debt. I know that a lot of my friends though, who have been accruing debt since undergrad are somewhere closer to 500,000. And I don't want to say that to scare you, but it's just the honest truth. As far as are there any programs that you recommend students look into? So what I would say is, getting specific, I wish I had done this sooner, is after you're done with kind of residency and fellowship and you're in practice, that's when your loans, you have to start kind of paying them. And actually, I think you can defer them only for a certain number of years. So I deferred them during fellowship. And then I started paying them when I became an attending. But you can refinance your loans to get lower interest rates. And I wish I had done that sooner, but that would be something that I would recommend doing and looking into. And if you have like any financial guidance or a mentor or someone you can talk to about that earlier on, I would recommend doing that. I don't know about specific programs, but what I will say is if you live in an underserved area, or if you think that might be something you'd be willing to do for, let's say, a couple of years, there are loan forgiveness programs. So if you are willing to live, let's say in like the Midwest somewhere where there's a really big need for doctors, they may offer you to pay off your loans. Also, some jobs will give that as a signing bonus. So they'll say up to $100,000 loan forgiveness. So when you're ready to apply for jobs, if that's an important factor, which it rightfully so, it's very expensive, then you can actually look for jobs specifically for that. And just a little comment on that. You don't have to feel overwhelmed that you have to find a job for yourself. There are tons of recruiters who are just out there to help you. So you can say, this is exactly what I'm looking for. Maybe a specific number even that you need as a sign-on bonus to help you pay for those. So there are kind of programs that you can look into that can help. But I would say the most common one is you have to work in an underserved area for about 10 years, and then they'll completely forgive your loans. Any other questions? And again, feel free to like DM me on Instagram, and I usually am able to get back to you guys within a day or so. And if you have any other questions or just want some guidance or mentorship, I'm always around. If you're in this area and you're thinking about maybe going into GI and you want to see what a day is like for me, I can try to arrange for you to come and see procedures. Right now, it's a little hard because they aren't letting everyone in with COVID. Like they aren't even letting spouses in the endoscopy center to wait in the waiting room. So once things get a little bit better and, open up a little bit more, hopefully that'll be easier. Then I'd be happy to kind of do that.
Okay, does anyone else have any more questions? If not, that will conclude our Q&A. And I want to thank everyone for coming. And I want to thank Dr. Kalra for, coming and answering our questions.
Sure. It was so nice to talk to you guys. Take care and good luck, all of you.
Okay.
So much.
Thank you.
Bye-bye.
Bye.